Hi, everyone. Welcome to our multi-heart lecture series. It's a great pleasure to have today Dr. Robert Mentz, who will be speaking about which diuretic are best in heart failure. He will be giving an update based on recent clinical trials. So it's a great honor to have Dr. Mentz today. He's an associate professor of medicine and chief of heart failure section at Duke University. He's also the editor-in-chief of the Journal of Cardiac Failure, the official journal of the Heart Failure Society of America. He is a leading clinical trialist in both traditional and pragmatic studies. He has the clinical lead for the HeartFit trial on IV iron on over 3,000 patients. He served as a co-PI of the Transform Heart Failure Pragmatic Trial on loop diuretics in about almost 3,000 patients with heart failure, and the PI of the Paraglide Heart Failure Trial on Entresto in acute heart failure with preserved ejection fraction. He has expertise in trial design and execution that supports the inclusion of diverse participants. He's a leader in site engagement with efficient recruitment that streamlines clinical studies to optimize data quality. He's also the co-PI for the FDA Research Triangle, CERSI, and he is an established mentor for medical students, residents, and fellows, and he was the recipient of the 2021 Clinical Research Mentoring Award from the Duke School of Medicine and the Proctor Harvey Award for the American College of Cardiology. It's a real honor to have you here. We were discussing before what an amazing career you're having. You graduated close to me from fellowship there at Duke, and you have over 500 publications. So congratulations, and thank you for joining us.
Wonderful. Thank you so much for the invitation. It's an honor to be with you. I'm looking forward to the discussion together. So over the next little bit, and these are my disclosures, I'm going to go through some of the background on the implications of congestion, which this group knows well, and talk about the role of decongestion in heart failure. Then I'm going to rapid fire go through the key studies that have helped build our evidence base of how we manage decongestion, and then some of the data specifically around Transform HF, a trial that I was fortunate to be involved with for the past decade or so. So just to anchor our discussion here a little bit, I love this framework of this older New England Journal paper from 1974, which talked about how to manage cardiac decompensation, diuretics, vasodilators, oxygen, consider inotropes if you need it. And Dr. Fonarow had this update, this really nice text in 2007, and said, it's pretty much the same. Diuretics, maybe some inotropes if needed, in addition to background therapies. This was the era of Niseratide as well, recombinant BNP. Importantly, I think still some underuse in many respects in terms of vasodilator therapies. So you say, well, where are we now? And I think we have come a long way in some respects, but still at the heart of this is loop diuretics, really, to adequately decongest. We increasingly appreciate and implement guideline-directed medical therapy, especially with the evolving data with ARNI and SGLT2 inhibitors. We think potential roles around adjunct agents, and I'll talk through some of those and highlight a little bit of the more recent data with acetazolamide, thiazides, and even thinking about things like tolvaptan. But that just anchors the conversation a little bit. But as we talk about congestion, this is a helpful framework. Regardless of how you look at it, congestion is bad. On the left, you can see signs and symptoms. In the middle of the screen, hemodynamics, specifically wedge pressure, and on the right, natriuretic peptide levels. So worse measures of congestion strongly associated with worse outcomes. And importantly, it's really congestion that drives clinical outcomes, even more so than cardiac index. And this was a nice paper that one of my former fellows, Lauren Cooper, led, where we looked in the ESCAPE trial data set and tried to better understand if we look at cardiac index less than 2 versus greater than 2, or wedge pressure, what really stratifies groups and has the greatest prognostic utility. And I would reckon that the majority or many of us often think, when you see that chart or you see that cath report that says cardiac index 1.9, that alarm bells are going off. You say, this is cardiogenic shock. I'm really worried about this patient. And certainly that is an important piece of the puzzle. But in and of itself, it doesn't give the total story. So what this nicely shows is actually that cardiac index, yes, it is important, and I'm not downplaying that cardiogenic shock picture, but it's really actually the wedge pressure that drives clinical outcomes. And I think this is broadly under-recognized in our field. And I would hope that over time that we really do have that recognition. When you see a wedge pressure of 20, 24, 30, that really is a marker of poor prognosis for that patient. And then this is from another one of my fellows, Drew Ambrosi, looking in the Everest trial, a really elegant study that then looked at just a congestion score and looked at outcomes based on the status of decongestion in these patients, and importantly saw that as you get greater decongestion before patients are going home after acute heart failure hospitalization, they do better. But another important message of this is that, unfortunately, still, despite our best efforts to decongest during the hospital stay, many of these patients are still going home with residual congestion. So again, underscoring the role of congestion, the importance of decongestion, and recognizing that it may have important prognostic value, even independent of cardiac index. And then this is a concept that I think has been much more widely recognized now, this idea of worsening renal function. And I remember during my residency, we were often taught the rule of threes. So when a patient comes in with acute heart failure, about 30% of them will have worsening renal function, defined by a creatinine of 0.3 increase within 3 days. That's pretty well held true in a multitude of different data sets now. So worsening renal function, really common, but Jeff Testani and then some work that our group did here to try to tease out, is all worsening renal function bad? I think the short answer is no, that actually if you decongest patients adequately, but you get a little bump in the creatinine, that's actually not associated with a worse outcome. It's really only if they have residual congestion and worsening renal function that you need to worry about that marker of renal injury. So I think the key message here is that when patients are in the hospital, we're decongesting, their creatinine is going up. Yes, we need to keep tabs on that, realizing that creatinine in and of itself is an imperfect measure, but really the goal is to adequately decongest. And I'm not downplaying the importance of when you're really getting a cardiorenal complex situation, thinking, do we need a right heart cath to better tease out and support our management? But a general principle that worsening renal function in the setting of adequate decongestion is not necessarily bad. So now let's talk some about our strategies to decongest. So loop diuretics, this is from the ESC guidelines, noting that the only class 1 recommendation for decongestion across ejection fraction spectrum is loop diuretics. And as we look at some of the key data and state-of-the-art reviews in this space, I'd give a shout out to this one led by one of my colleagues here at Duke, Mike Felker, on loop diuretics, and just these beautiful figures, amazing synthesis of the literature that we have to date. So I'll refer you to this for a deep dive into diuretics and some of the background and understanding. So with that background now, I'm going to go through rapid fire a number of trials. Then I want to make sure to leave plenty of time for discussion. So I'll probably go a little bit quickly through this. For those in the cardiology and specifically heart failure space, this trial will be on every single one of your board exams, and is, despite only being just over 300 patients, is one of the strongest that informs our evidence base. So DOSE AHF was a heart failure network trial funded by the NIH, just over 300 patients. An important study design, it was factorial, 2 by 2, meaning each patient was actually randomized to 2 different strata. So it was the dose of diuretic, high dose versus low dose, underscoring that the high dose was 2.5 times their oral dose. So whatever they were on at home, oral, you multiply that by 2.5, then you gave that intravenously. And then it was also randomization to bolus dosing, meaning BID bolus dosing, or twice daily, or a continuous infusion. And what this looked at was a number of important measures. It looked at the co-primary endpoints at 72 hours of this global assessment, as well as a measure looking at changes in creatinine, and then looked at clinical outcomes through 60 days. Ultimately, what the trial showed was no benefit on this primary endpoint for patient global assessment. However, when looking at the high dose versus low dose, a number of important signals suggesting a potential benefit of higher dose IV diuretics around dyspnea relief, freedom from congestion, more weight loss, volume loss, at the cost or the risk of, we do see this bump in creatinine in the first couple of days, but actually by 60 days, no difference between the groups. So the central take-home message here is to give high dose IV diuretics 2.5 times the oral dose. And there was no difference between bolus and continuous infusion. Importantly, despite these data, I think sometimes we still use a continuous infusion drip in practice if it's either for implementation or logistical reasons for a patient, but the data really do not support benefits around these measures in this modest size study with a continuous infusion, but emphasizing the importance of high dose loop diuretics. And unfortunately, I still think we see a lot of patient came into the ER, they got 20 or 40 IV furosemide. Really, in the vast majority of these patients with established disease, they're going to need higher doses. And I'm going to return to some of the protocols that have come out more recently, as well as using other measures like urinary sodium to actually guide our approach. So the CARESS trial was another NIH Heart Failure Network study. I'm just going to note this because I think what was helpful, it was looking at ultrafiltration, but actually the comparator arm in almost 200 patients, ref or PEF in the hospital, was this step pharmacologic care. So it wasn't just standard care, it was actually this step pharmacologic care targeting urine output of 3 to 5 liters. If you weren't meeting these marks, then you had to increase loop diuretic, add a thiazide, consider other agents or vasodilators. I think that that's helpful because it did give us these important data around some protocolization of our approach, but still leaving room for individualizing it to the patient. But this study, also for those interested in trials, had a pretty cool primary endpoint, this bivariate change. So on the left, you can see it compared these two groups of the pharmacologic care that was stepped versus ultrafiltration and looked at how much weight change was there. And you can see on that horizontal axis, it was about the same amount of weight change. And then the vertical axis is the change in renal function. So in this case, ultrafiltration actually led to worse renal function. And then on the right of the screen, you can see there were more adverse events related to having the PICC line and being on heparin and things. So for those that think about things like ultrafiltration, the data really don't support routine use of this. But then the specific message I wanted to underscore was around this idea of, are there advantages maybe to protocolizing some of this and making sure that we're not just giving some diuretic, maybe checking some afternoon labs and then seeing how things look the next day on rounds when we say, how negative were they? And then they say, oh, they were 400 milliliters negative, and saying, oh, well, I guess we'll give more diuretic today. This idea of let's better stay on top of things and track our progress and have some key metrics that we're going for. For those that want a deeper dive into these details around diuretics and decongestion, this is the best paper I think out there. This is from the European Society of Cardiology. And they take this deep dive into all of the different recommendations. And I think a lot of this has now been tested in studies, as I'll note. There's this beautiful figure that talks about, it's a throwback to kind of our training days, as we think of the specific mechanisms of action. You know, for instance, I'll talk about the ADVOR trial with acetazolamide. Admittedly, I hadn't kind of thought about this in a long time about where is this actually acting within the nephron, where in the specific mechanisms around this that play into adverse effects and the lab values and things we need to monitor. So I won't belabor some of these points, but I'll refer you to this paper. They do have this interesting treatment algorithm that at the time of publication really didn't have all the data behind it, but now has been prospectively evaluated. Admittedly, at our institution, we don't incorporate these elements yet, but actually we're going to have an upcoming journal club in a discussion about this. But this idea of let's start with that dose trial, 2.5 times their home diuretic, but actually using urine sodium and following more closely the urine output over the course of time. So do you give your diuretic 2 hours later, you do a spot urine sodium, and you want to see higher levels of sodium in the urine, greater than 50 or 70, have been tested in a couple different studies. And if you're not meeting those marks, don't just wait till the next day, but you need to think about combination therapies. So this was the first time in one of these position statements, they laid out this algorithm that now has actually been tested in 2 different studies. The first was presented at ESC Heart Failure, the ENACT Heart Failure trial. This was open label, non-randomized. So we do need to have caution here about the strengths of the data, but it basically had 2 phases. They kind of did the usual care piece, and then subsequent to that, they used this protocol where they used urine sodium at 6 hours, remembering that that last algorithm was looking at 2 hours. But looking at 6 hours, seeing how much urine sodium you're getting, and if you're not adequate, greater than 50, or the urine output's insufficient, then you ramp things up on the diuretic side or add other adjunctive therapies. So these data were presented. I don't think they'd yet been published, but the ENACT HF trial did show more natriuresis, more diuresis using this urine sodium guided approach, and actually suggested a reduction maybe even in length of stay. So again, non-randomized pragmatic study. But then I think this study didn't get enough buzz. This was presented at ESC. So open label randomized trial now, over 300 patients, acute heart failure. In the intervention group, it was natriuresis and actually having a number of urine sodium assessments, 2 hours, 6 hours, 12 hours. You can see the schedule of events here, but really making sure that intensifying to target is urine sodium of greater than 70. So this study was published simultaneously in Nature Medicine. It met one of its two co-primary endpoints. On the left, you can see there was more natriuresis when you use this approach. And you can see at the top, the specific values there at 24 hours, 409 versus 349 millimoles of urinary sodium. No difference in clinical outcomes on the right, certainly not powered adequately for that in this modest 300 patient study, but maybe some suggestion of a numerical reduction there. Need larger studies to assess that, but did see greater diuresis in that group. No difference in length of stay observed here. So those are two of the key protocolized diuretic intensification studies. The ADVOR study, this was presented at ESC over a year ago now, published in New England Journal. My general feeling, I think this was a well-conducted trial. It's modest in size, 500 patients. I think the application of this by some has probably been overextended a little bit, but the intervention here was in acute heart failure, ref or PEF, giving acetazolamide 500 IV for 3 days. IV is much more expensive. At our institution, when we use this, we usually do it oral. We don't have those prospective data. Importantly, the trial excluded SGLT2 inhibitors and it excluded those with more significant renal impairment. It was a positive trial showing that acetazolamide led to greater decongestion. And then on the right side of the screen, you can see some suggestion of more diuresis, more natriuresis. So I think that this got a lot of buzz. There was excitement. Should we be using acetazolamide more consistently in our patients? There's this paper that just came out by Wilfred Mullins, one of the investigators, that I think gives greater balance to the pros and the cons of this approach. On the right side of the screen are the cons. I'll emphasize these. It did exclude SGLT2 inhibitors, and there is some questionable significance around the urine output measures. And there was actually worse renal function with this intervention, keeping in mind some of our earlier conversations as seen in dose and some of the other studies, as I'll note. And we don't yet have the data around clinical outcomes. And in fact, actually, it looks like death is on the wrong side of the clinical outcomes. So we'll have to see. But I think in general, some data now to suggest as you're decongesting, there might be some benefits if you're struggling to think about acetazolamide. The chlorotic study was a thiazide in acute heart failure. So this was oral thiazide for 5 days with the dose based on what the patient's GFR was. Just over 200 patients, both ref and PEF, and did show that by adding a thiazide, there was more weight loss, but no difference in dyspnea, but maybe more diuresis, and again, more worsening renal function. So as we start to string these together, I think keeping in mind loop diuretics with these data are the mainstay, making sure you use the high dose, thinking about adjunctive agents, maybe incorporating urine sodium. And I'd love to hear what you all are doing there in our discussion period around some of these different approaches. We often more consistently use metolazone or other thiazide, more impactful loop thiazide diuretics to help augment our loop diuretic. The Athena trial in this rapid fire series that I'm going through, this might not be as well known by some. This was also a NIH Heart Failure Network trial. It looked at high dose MRAs and acute heart failure there's some really nice early studies that said with this sequential nephron blockade, with high dose MRAs, even some of the doses we use in patients with cirrhosis, is that going to lead to benefits? In 360 patients, both REF and PEF, with a little bit of complexity around the design, because if you were on spironolactone for HFrEF, where there was an indication, then you continued on that low dose. So the comparator, there's a little bit of complexity there, but a nice study design, but unfortunately showed no difference in any of these surrogate measures. So no real data to support higher dose MRAs, but certainly emphasizing the role around GDMT, especially in HFrEF. So with all that background, now I'll chat in this last little bit about Transform, which has been my baby for the past decade or so now. So I was fortunate to have exceptional mentorship with Chris O'Connor, Eric Velasquez, and Bert Pitt as a fellow. We began these conversations at the CVCT meeting when I was during my fellowship. And Dr. Pitt and others noted that torsemide has these advantages over furosemide. And most commonly what you hear on rounds is torsemide is better absorbed in the setting of gut edema. It has a longer half-life. But in truth, some of the earlier studies don't always support some of those measures, but there are some data to suggest more consistent oral bioavailability, especially in patients with heart failure and renal disease. It's not impacted by food and others, like some of the loop diuretics are. In the middle of the screen, this was new to me as we began developing this trial. There were these nice studies out of Spain that actually demonstrated in a randomized fashion that torsemide has antifibrotic effects that you don't see with furosemide. And they did all these nice studies to show where on this collagen formation axis is torsemide potentially acting, looking at both local markers in the heart as well as circulating markers. So some data, just not that torsemide has a potential advantageous pharmacologic profile, but is it actually maybe even similar to MRAs, but acting at a different step in the fibrotic pathways. And then on the right was an observational kind of pooled analysis that suggested maybe can it reduce clinical outcomes on this backdrop of the pharmacologic profile and these antifibrotic effects. So with that background, we then conducted a couple different studies. We looked at Duke data, we looked at a number of trial data sets that suggested that patients who get torsemide, they tend to be sicker than those who are getting furosemide. And patients commonly move through they get started on furosemide when they're first diagnosed with heart failure. Is they're not responding to that or needing higher doses of furosemide, they're furosemide failures, then somebody switches them to torsemide. But if you match patients and try to do this inverse probability weighting, that it does look like there might actually be some association between torsemide and improved clinical outcomes. So with that, we developed and executed this randomized trial. This was a pragmatic study looking at a treatment strategy in patients hospitalized with heart failure, regardless of ejection fraction. It's 60 US sites. It was 2859 patients. Initially, we designed this to be 6,000 patients, but it was event-driven with a primary endpoint of all-cause mortality. Given the broad eligibility criteria where pretty much anybody in the hospital with heart failure, if they were going home on a loop diuretic, they were eligible. It led to really a sick population of patients with lots of events. So we actually finished our recruitment and closed out the trial early. But it was one-to-one randomization to a strategy of torsemide or furosemide with the dose selected by clinicians. And there was some variability. At our institution, we used 2-to-1, meaning if you were on furosemide 40, that would be torsemide 20. Some institutions used more of a 4-to-1, meaning you use even less torsemide. And I'll come back to this at the end with some tantalizing kind of initial data from a sub-study we did. But it was, patients got randomized. We tried our best to support adherence to the randomized therapy, but then all of the follow-up was centralized by the DCRI call center. And then we collected mortality, hospitalizations, quality of life, and did have adequate events with this event-driven trial. I do want to talk a little bit about the baseline characteristics because I think this probably best represents the heart failure population that we see at many institutions around the US. You can see actually in our case, it was more than a third women, more than a third Black individuals. Based on the services that recruited, we had less HFpEF than we'd initially hoped. And that just was based on, this was more cardiology, less gen med, and more specifically, more advanced heart failure services too. You can see the high natriuretic peptide level here, pretty low ischemic etiology. And I think this is linked to some of the racial diversity, importantly, that we saw in the younger age as well. You can see the background therapy on the right. It was only 8% SGLT2 inhibitor based on when the trial recruited. But as you all probably saw, so there was no difference in the primary endpoint of all-cause mortality, no differences across any of the subgroups, a really high event rate, but the lines were pretty much on top of each other. And many people say, well, why the heck would you do a trial thinking a diuretic is going to reduce all-cause mortality? And we felt it was important to do that to have an ungameable endpoint in the setting of an open label trial. But from a trialist perspective, it's pretty interesting. Even if we missed on all-cause mortality, we felt that if we did show differences in hospitalization, that would move the needle and change clinical practice. So there's some nuance around this selection here, but that was the reason we chose all-cause mortality. But our other secondary endpoints on the top right is all-cause mortality and all-cause hospitalization. So not heart failure, but actually all-cause hospitalization. 8% relative reduction, not significant, but I'll show you some of the additional data that I think may start to build a case that if you've got two generic therapies and one is leading to numerical reductions in hospitalizations, all-cause hospitalizations, it may be reasonable to consider that, realizing it's overall neutral trial. But there were numerically fewer total hospitalizations. And putting this in context, if this had been a significant reduction in hospitalization with this, it's about 50, the NNT or the number needed to treat is about 50 actually to prevent one event. So it's not horrible as you think, but again, this is all hypothesis generating. Quality of life was another measure we wanted to look at. No significant difference. You can see at month 1 with KCCQ or Kansas City Cardiomyopathy Questionnaire, 1.4 point difference. So not what we typically think of as clinically significant of 5 or more. There are some patients who may respond better with this earlier improvement in quality of life, and we're still exploring some of those details. But overall, a neutral trial, but some important insights from some of the pre-specified on treatment analyses as well as exploratory analyses. So I'd almost say that some of the crossover and these data are maybe even more informative than some of the primary results. But as we look overall, those patients with known diuretic status, as we look through now, at the time of discharge, there was already 5% crossover. That's pretty significant. It's actually numerically different. On the left is torsemide, so 7% crossover at the time of discharge versus 4 in the furosemide. This was a little different than we'd expected. We thought that there actually would be more crossover to the torsemide group, thinking, oh goodness, this patient's not responding to furosemide, some of these carryovers of our anecdotal medicine. But actually 3% not on a loop diuretic at discharge. And some of those certainly did come back on a diuretic later. Maybe it was a little worsening of renal function and they said, hold it for a couple of days. But that was pretty striking. And then as you go out to 30 days, 7% crossover with some imbalances between the two groups. It's a little bit higher in the torsemide group, and then 7% on no loop diuretic. So I think that does start to put together a story of, would you anticipate a difference between these two therapies if 7% by that 1 month time point aren't even on the therapy? And then, so in our pre-specified analyses, this is the intention to treat. Again, I'll draw your attention to the composite with hospitalization, 8% relative reduction, not significant. But in the on-treatment analysis at discharge in 30 days, I'll draw your attention to the bottom right. Actually, the hazard ratio is 0.89 with a p-value of 0.1, with confidence intervals 95% that just crossed the line of unity. And our expert statisticians have pushed us to say, does this actually represent in this real world comparative effectiveness trial, is this actually maybe getting closer to reality because these patients at 30 days, they're the ones actually that are on the randomized therapy. This is all well pre-specified. It's hypothesis generating, but I think suggesting maybe there is a reduction in hospitalization. And we've got some ongoing work now to adjudicate events to see about heart failure specific events. And then this is a time where that reviewer too, in her paper at JAMA actually gave a really super helpful suggestion. They gave a recommendation around a competing risk model looking at all-cause hospitalization where you account for this really high mortality. It was 20% mortality at 1 year. And interestingly, all-cause hospitalizations, when you do this competing risk analysis, this is all post hoc, but actually a 12-13% relative risk reduction. That's clinically meaningful. So to me, I think that this does shed some light on a potential role of torsemide, even though the trial itself was neutral. So our conclusions on this, and then I'll show you a little bit of some of the insights around data that are not yet published from an ancillary study that we had, but overall showing that a strategy of torsemide had similar effectiveness for clinical outcomes to furosemide, emphasizing the appropriateness of focusing on diuretic dose and initiating and titrating GDMT, thinking that a lot of the insights actually came from our pragmatic trial design. For those that don't live in this space, it's pretty striking that in the US, in heart failure trials, the average recruitment is about 0.2 patients per site per month, which means that it's about every 5 months or so patients are recruiting, or a site's recruiting a patient. That's pretty lousy. In our trial pre-pandemic, we were recruiting more than 2 patients per site per month. So I think this is an opportunity to think, can we have more efficient trials that do reflect the patients that in terms of diversity that we actually see in clinical practice and answer more of these questions? And we've got some upcoming studies we're hopefully going to be able to launch that will answer other really meaningful questions. I'd be remiss if I didn't thank a huge team, including some of those at your institution who helped participate in this. To give you some context of how long this takes. So again, I started developing this as a fellow. This is not how long the trial took, but from developing the grant, these are my 3 kids on the left. And then when we presented it in last year, right at AHA, so just about a year ago, this was at our family camp we go to in the summers, in our tie-dye shirts we just made, the age of the kids, right? So my daughter was basically a baby, and now at this time she was, it just turned 8 years old. So just to give you some sense, it's a tremendous joy to work with this team, but it does certainly take a long time. And then finally, to give you a little bit of a teaser here, so this was a beautiful study that Jeff Testani did at just 3 centers, looking at really deep phenotyping of the cardiorenal effects of these different diuretics. So they got a ton of different blood and urine biomarkers in these 88 patients at baseline and 30 days, did all this blood volume work. And their hypotheses were thinking that torsemide is going to have these important PK and PD benefits. It's going to have better bioavailability, a longer duration of action, potential antifibrotic effects, and that all the data would really support this 2-to-1 ratio. We're smart clinicians. This is what we see. It's got to be 2-to-1. And ultimately, the short answer is all of it was wrong. So what he showed, and again, these data aren't yet published, and he's allowed me to share them with the group, but basically showed actually that furosemide had better renal bioavailability. Again, these are protein bound. There's some nuance about what's actually happening at the nephron. But on the left, you can see furosemide, the percent of dose excreted in the urine, getting to the kidney. Actually, furosemide, more bioavailability. And then on the right, the kinetics were unexpected. Actually, with furosemide, you get this, it takes a little bit longer to peak, but it actually has this longer period that it may last. Whereas torsemide, you're getting a more abrupt up and down. So we're still working to better understand this, but that combined with the diuretic dose equivalence. So on the right of the screen, you can see they did this cool figure that shows as you're looking at fractional excretion of sodium, what is the right dose conversion? And actually, it looks closer to 4-to-1, which then has led me to believe, and we have some biomarker data to support this, that we weren't really comparing apples to apples with our furosemide, torsemide, and dose, but in fact, the torsemide group may have been overdosed. And we actually do see markers of renal dysfunction and more sympathetic activation with torsemide in those higher dose patients. So more to come around that. But in closing, appreciate your attention going through this whirlwind, talking about congestion and the importance of decongestion, all of these different, what I think are landmark studies, but many of them actually smaller in size, but looking at high dose loop diuretics, decongestion protocols. Should we be thinking about urine sodium? Are we incorporating acetazolamide? We're not routinely, but do more commonly use thiazides. But then around Transform, again, a really fun study to conduct, including in collaboration with investigators there. But this idea of let's get the right dose, and I think we'll share more insights around that in upcoming months. Thank you so much for your attention. I'm looking forward to hearing thoughts and discussing with you.
Thank you very much. That was an amazing lecture, and what your kids are beautiful. So congratulations on that as well. So please put your questions in the Q&A, and we can start with the first question. I don't know if Dr. Jordi or Garcia would like to start.
I have one. So from my perspective, which have an interest in heart failure with preserved ejection fraction, is your approach for diuretic escalation different in the two groups?
Yeah, it's a great question. I think broadly speaking, it's not. In dose, it included both HFrEF and HFpEF, and in general, the data were consistent about using higher doses. But to your point, I'd be curious what you think, because some of the data from studies like CARES and otherwise did suggest that there are probably important differences around decongestion and diuretic strategy. And now I'm really struck, having more recently presented the Paraglide data with ARNI and HFpEF. We've often focused on this less than 60 for EF versus greater. And everything we're looking at shows us that in that case with ARNI, like all of the benefits from ARNI are EF less than 60%, and all of the risks are EF greater than 60%, with a lot of symptomatic hypotension with ARNI. It does make me think more in that context around natriuresis and things that we see with neprilysin inhibition. Do we need to be thinking about differences, different strategies or timing with diuretics? What do you think?
I mean, the reason why I raised that question is that, we see more frequently AKI in the HFpEF patients when you really escalate dosing. Mm-hmm. At least that's been my experience. I don't know, if you agree.
Yeah, I think that's an excellent point, and it kind of leads to what I wanted to ask you. First of all, great lecture and amazing productivity over the period, not just the growing up of your kids that look very well. Initially, I thought you had another kid, but then I realized in hindsight that was your wife who right now entered the picture. So you can pass that on to her.
I will.
But the question, as you know, I think we as a field, we're trying to make the diuretic usage better. You have made major contributions to this. And then there is this huge gap between what we know and what we do, or what others do and is being implemented. I won't go there. That's something every hospital struggles with. I'm sure you do that too. My question to you is, at the bedside, how do you define, and urine sodium is certainly one thing, but may not be entirely practical, right? In a regular hospital, a regular ward, to check the urine sodium, have it come back, redouble. How do you define diuretic refractoriness? And then once you have defined that, there's obviously the emerging field of device therapy for diuretic refractory patients. That's what Mario alluded to. We see clinicians, we see this, the creatinine goes up, what now? And there are now so many new devices, and we don't have to discuss them, but where do you think is the point where, starting an investigational device protocol, for example, would be reasonable? When have diuretics failed?
Yeah, thank you. Really good questions. I think you're right. How do we define diuretic refractory or diuretic resistance? It's probably not practical to be checking urine sodium. Jeff Testani and many others there at your institution have done nice work basically just looking at how much diuretic are you giving and how much urine is coming out, and incorporating some element of renal function in there as well, maybe. But I still think we're pretty rudimentary, right? So you give 80 or 120 of IV furosemide in the morning, and then you say, hey, let's check back in the afternoon and see how much urine we've got. And, we check things like weight. But in general, these are such poor measures, right? And this idea of even with our best tracking of what's going in and what's coming out in a hospital, say, it's often probably not that accurate. So it gives me a general sense of, I think we need to give lots of diuretic and monitor the measures that we can, specifically physical exam and renal function and patient response. But I'm increasingly worried that if we decongest these patients, we know that pretty quickly they feel a lot better. But as Mihai Georgiadis used to say, there's like this entire iceberg of congestion, right? Like the symptomatic piece is only that tip of it. And we know we help them feel better pretty quickly. They may say, hey, doc, let me go home. I feel better, but they've got all of this decongestion. So as I put it together, I think diuretic resistance is a real thing, but the majority of what we're calling it is probably we haven't given enough diuretic. But if you actually given enough diuretic, then I think, and you're still not getting enough urine output, then we've just got to give some of these adjunct agents. And then to your question, I'm really intrigued by some of the different device approaches. In full disclosure, I sit on the DSMB for some of the ongoing studies that are looking at this, including one that I find kind of mind-boggling. This idea, it's similar to like an ultrafiltration approach, or drawing off tons of fluid and then actually replacing it with saline as well. Which on one hand you say that doesn't make any sense, but then you might say, well, we've been doing the same thing for a long time. Maybe we were wrong this whole time. So I think we do need to test these different ones. So I'd say, this, and as a trialist, I really like the idea of let's engage with our patients. Ideally, you'd love to see like every patient as part of some study to help inform not only their care, but future patients. So I, in general, of the mindset of let's test out these devices in a controlled and thoughtful way and see how we can best help our patients. And maybe would even put a teaser that there were all these studies out of Italy, some of which unfortunately have kind of been maybe called into question a little bit around hypertonic saline. And I think that too, that was something we wanted to test in the Heart Failure Network, but we're never able to. This idea of if you give a ton of diuretic and give hypertonic saline in concert, does that lead to advantages? And unfortunately, we really don't know. But I'd be curious what you all are doing around thiazides, acetazolamide, SGLT2.
Yeah, we have a diuretic pathway here. Again, we have the pathway. I can't say it's 100% implemented. That basically calls for an opening dose of diuretic that is double your home PO. Like if you're on 40 of Lasix PO at home, you're supposed to get 80, and 80 is the starting dose, the highest starting dose. So if you're anything at 80 first, if you don't have urine output after 4 hours of at least 100 cc per hour, you're supposed to double that dose, or at clinician preference, give metolazone, because as you alluded to, is much cheaper than IV, pure metolazone rather than IV diuretic. And that's, if that gets done in the ER or on admission, you are very much ahead of usual the next morning when somebody actually comes to look at you. So that's our pathway, early reach for those other diuretics. In terms of, I'm a little bit using this podium here to convince you what we're trying to get done with the FDA, which is to move away from what they usually now request. If you have 2,000 cc's of urine, nothing investigation will be justified, which I personally believe, and many others, that's wrong. It's really should be about how net negative have you become. Because if you get 2,000 out and 2,000 in every day for 7 days, then you are where we usually are, which is nowhere. And you go home with, and actually Georgiade had published this, you go home 1 kilogram less than you came in, still totally fluid overloaded. But having been in bed for a week, I feel a lot better.
Yeah.
Yeah, there are some questions in the chat. I think there was a question.
I'd like to ask a question first, if you don't mind. So for these trials, we usually include heart failure patients regardless of their diagnosis. My question is, should we be phenotyping with cardiac MRI so we know actually what we're treating instead of just including all heart failure as the same?
Yeah, it's a good question. I mean, imagine you had a family member with a new diagnosis of heart failure. Wouldn't you want them to get a cardiac MRI to make sure you're not missing something else that would importantly modify your treatment algorithm? I mean, that's unfortunately kind of not practical from just logistics or cost reasons, but I do hope that increasingly we better phenotype heart failure, whether that means genetic in some cases and or pulling in their comorbidities and thinking, how do we best incorporate a personalized management plan? Unfortunately, like a lot of our data, these big trials that were well done, it kind of took all comers, whether it was HFrEF trials or HFpEF, and it kind of gave these drugs, not a phenotype specific one. But yeah, I do think that there is hope for that maybe down the line a little bit. What do you think?
I mean, I'm biased because I do advanced imaging, but I usually try to get it for my patients. And the question is, like you're saying, cardiac MRI can't be used for every single patient. So I think hopefully we start to narrow it down to which patients actually, or which signs from echo, which signs from the EKG, which patients actually benefit from this. So I mean, we personally use it in the ones that we think amyloid, these other cardiomyopathies that have a higher yield, but hopefully with machine learning and some new tools, we'll be able to have a better tool for that.
Yeah, so I have to, as a supervisory panel member, make a conflict of interest declaration. Yeah, Leandro is a well-known cardiac MRI specialist. So asking him whether everybody should get an MRI is like asking the barber if you need a haircut. Having said that, I do agree with this assessment. I'm sure Mario does too. I think we're going close on time. This was really terrific, Rob. Thanks so much. Amazing overview, and it's always great when people speak that have actually done the work. So congratulations on that. And we hope to have you in person. And I already gave you the teaser on the #1 unknown Mexican restaurant in the Bronx that was recently written up in the New York Times. So we may be too late, but we will take you there so you can assess the quality. Yeah.
That'd be incredible. Thank you so much. I appreciate the invite. And
yes, thanks for making time for us.
Thank you so much.
Thanks so much.
Take care.
Bye-bye.